This animated line graph tracks the U.S. labor induction rate over recent years. By 2022, 31.9% of all births required medical induction of labor. Patients undergoing induction spend a median of 20 hours on the labor and delivery unit, compared to 14 hours for expectant management. As the volume of elective and indicated early-term deliveries increases, hospitals face severe logistical bottlenecks, stretching unit capacity and clinical resources to their absolute limits. To safely accelerate the admission to delivery interval, the American College of Obstetricians and Gynecologists released Clinical Practice Guideline No. 9 in July 2025. This framework establishes the new operational standard for patients with term, singleton, vertex pregnancies, and intact membranes. Reducing unit length of stay requires moving away from the isolated use of either a balloon catheter or a single medication. The clinical data supports integrating these approaches to clear unit backlog. Researchers recently conducted a network meta-analysis encompassing more than 40,000 patients across 207 randomized controlled trials. A network meta-analysis is a technique for comparing 3 or more interventions simultaneously by combining both direct and indirect evidence across a network of studies. This specific analysis evaluated the safety and efficacy of every available cervical ripening strategy. One protocol proved statistically superior. The most effective approach pairs a 30 milliliter Foley balloon with 25 micrograms of vaginal misoprostol. This combination yields the highest odds of vaginal delivery within 24 hours, lowest odds of cesarean delivery, and reduced neonatal intensive care admissions. Misoprostol alters the cellular matrix by causing collagen bundles to weaken and lose strength. When you combine this chemical softening with the physical circumferential pressure of a mechanical balloon, the cervix effaces and dilates faster than either method achieves alone. When mechanical methods are absent, pharmacologic agents are standard. Among these, misoprostol consistently outperforms dinoprostone. It increases 24-hour vaginal deliveries, requires less oxytocin augmentation, costs significantly less, and needs no refrigeration. Comparing misoprostol routes, the vaginal route of 25 micrograms shortens the induction to delivery interval and reduces supplemental oxytocin needs. The oral route, using 50 micrograms or less, lowers the risk of tachysystole, defined as over 5 contractions in 10 minutes, protecting the fetal heart rate. All prostaglandins, including misoprostol, carry a severe risk of uterine rupture in certain populations. These medications are strictly contraindicated for any patient with a history of uterine surgery, including previous cesarean deliveries. Choosing between the oral and vaginal route requires balancing the operational need for clinical speed against the medical necessity for fetal stability and maternal comfort. The 2025 ACOG guideline provides clear instructions for updating hospital operations. Labor and delivery units relying exclusively on single-agent ripening protocols need to revise their standard admission orders. Clinicians should implement combined mechanical balloon and misoprostol regimens for appropriate candidates. This dual approach directly addresses unit overcrowding by minimizing the hours patients spend occupying a bed before active labor begins. The guidelines also formalize a trauma-informed approach to induction. By offering oral misoprostol instead of vaginal administration, clinicians reduce the number of invasive pelvic examinations required, prioritizing patient autonomy and minimizing physical distress. For patients without complications, ACOG now issues a conditional, high-quality endorsement for outpatient cervical ripening. Hospital administrators and obstetric directors should begin structuring outpatient protocols. Allowing low-risk patients to safely begin the ripening process at home shifts hours of early labor management off the hospital floor entirely. By implementing combined balloon and misoprostol methods, selecting the appropriate medication route based on patient history, and establishing outpatient options, obstetrics teams will systematically shorten the admission to delivery interval and improve the overall patient experience.